I just want to thank you so much for this opportunity of presenting on this platform. Indeed, it is a rare privilege. I also want to thank everyone for attending this Zoom meeting. So without wasting much of your time, as Madam Towera said, my name is Joyce Nanyangwe, a radiography technologist, and I'm pursuing a bachelor's degree in medical sonography at Apex University here in Lusaka, Zambia. So my presentation tonight is on cholecystitis. This is a case study that I did when I was doing my attachment at Mainasoko Hospital some few months ago. This is the table of the contents. I'll run you through. So there's acknowledgement, objectives, introduction, types of cholecystitis, clinical history, clinical hypothesis, investigative imaging, sonographic findings, clinical correlation, limitation, conclusion, and references. So at the end of this presentation, I expect everyone who has attended to be able to define cholecystitis, to describe how it comes about, to identify the types of cholecystitis, to list the signs and symptoms of cholecystitis, and also to list the causes of cholecystitis. Before I talk about cholecystitis, let me first and foremost express my profound gratitude to the 2 female patients and to our supervisors at Mainasoko Hospital for their contributions to the completion of my case study, which is titled Cholecystitis. So, cholecystitis is an inflammation of the gallbladder. The gallbladder is a small digestive organ that is found beneath the liver. One of its main functions is to store bile and concentrate bile from the liver. Bile is a yellowish green fluid that is secreted by the liver and contains bile acids, which aid in fat digestion and absorption. Bile flows through the bile ducts into the duodenum. The duodenum is the first section of the small intestine. After filling the bile ducts, this is the common bile duct, it overflows into the gallbladder where it is stored for later use. The gallbladder, the normal gallbladder measures approximately about 7 to 10 centimeters in length, 3 to 4 centimeters in transverse diameter, and its wall is less than 3 millimeters thick when normal. So this is the image of the gallbladder. As I said earlier on, the gallbladder lies beneath the liver. This is the liver here, and this is the right lobe of the liver and the left lobe of the liver. So when we come to this image, these which are looking like branches of trees are hepatic ducts. These are the ducts that when the liver secretes the bile, the bile flows through these ducts all the way coming here. And this duct, which we are seeing here coming from the gallbladder, this is the gallbladder. And this is the duct that transports bile from the gallbladder and also transports bile to the gallbladder. So this duct is known as the cystic duct. These ducts coming from the left side of the left lobe of the liver are known as hepatic ducts. And the ones coming from the right side of the liver are right hepatic ducts as well. So when they come here, they join together to form the common hepatic duct. Sorry, the common bile duct. This common bile duct is the one that now transports the bile coming from the gallbladder and the liver into the first part of the intestines, the small intestines, that is the duodenum. These are sonograms of a full distended gallbladder. The gallbladder is divided into parts. So the part here, up here, this is a sonogram of the gallbladder, is the fundus. Then we have the body and the neck here. So this black fluid that you're seeing inside is the bile in the gallbladder. And when we look at this gallbladder, when we look at the walls of the gallbladder in transverse view here, the walls are quite thin, meaning they are measuring less than 3 millimeters thick. This is another, these are another form, another images of a distended, a large, normal, fully distended gallbladder. This is a transverse view. If we can see closely, it's well distended, full with bile. And this is a transverse view of the gallbladder. Since we are talking about cholecystitis, and cholecystitis is an inflammation of the gallbladder, when we look at these walls, they are quite thin. So a normal distended gallbladder is supposed to have thin walls. Types of cholecystitis. We have more than 4 types of cholecystitis, but tonight I'll only mention 4. These are acute cholecystitis, emphysematous cholecystitis or acute gaseous cholecystitis, chronic cholecystitis, and acalculous cholecystitis. So acute cholecystitis is an inflammation of the gallbladder secondary to an obstruction of the cystic duct by gallstones. Gallstones are hardened deposits within the fluid in the gallbladder. They are caused when bile contains too much cholesterol or bilirubin. Sometimes they are formed when the gallbladder does not empty completely or often enough. Acute cholecystitis is frequently seen in women, especially women who have had children before. This is due to differences in hormone production between males and females. In females, there is more estrogen and progesterone, and these hormones lead to slower emptying and increased cholesterol to bile. This leads to supersaturation of bile, meaning the bile will be thickened more, and this causes sludge in the gallbladder. Sludge is a thick material that cannot be absorbed by bile in the gallbladder. Then emphysematous cholecystitis or acute gaseous cholecystitis is a rare and deadly variant of cholecystitis. It's common in men and occurs when gas develops in the gallbladder wall. This gas is emitted by bacteria, and this can result due to inadequate blood flow to the gallbladder. The bacteria involved in emphysematous cholecystitis is Clostridium and E. coli. Most patients who suffer from this type of cholecystitis are diabetic patients, because diabetic patients have higher forms of fat that accumulates in the blood. This fat can also lead to gallstones and inadequate blood flow to the gallbladder. So when the fat accumulates in the cystic artery is the artery that supplies blood to the gallbladder. When it's filled up with cholesterol, there will be blockage of flow of blood to the gallbladder, and this may cause inadequate blood flow to the gallbladder. So when there's inadequate blood flow to the gallbladder cells will die, and this may cause what is known what is known as gangrene of the gallbladder walls. When this happens, it is considered as a surgical emergency because if care is not taken, the gas may spread to other parts of the body. Sometimes emphysematous cholecystitis may be difficult to see on ultrasound, but the gas within the walls may cause a dirty acoustic shadowing with a ring down or cometal artifact. So as sonographers or people who are practicing ultrasound, we must pay close attention to emphysematous cholecystitis because sometimes it's missed on ultrasound. Chronic cholecystitis. Chronic cholecystitis is as a result of recurrent cholecystitis, meaning the course of the disease has lasted for more than 3 months. Chronic cholecystitis is caused by gallstones. The swelling and irritation of the gallbladder continues over time. So chronic means you've had the disease for more than 3 months, and this disease may cause the thickening of the gallbladder walls, and when the walls are thickened, they'll cause irritation and pain to the patient. This type of cholecystitis may also cause tissue death. It's common in older people and those who have diabetes. Acalculous cholecystitis is a form of cholecystitis that is caused by dysfunction of gallbladder emptying. Acalculous cholecystitis is caused by severe trauma or burn, surgery, long-term starvation, sepsis, and dehydration. Underlying diseases such as cardiovascular diseases and diabetes may also cause acalculous cholecystitis. So the causes of cholecystitis are gallstones, bacterial infection in bile duct system. The bile duct system can have bacterial infection even when there is an infection in the small intestines. As I said earlier on, the common bile duct joins to the small intestines when transporting the bile. So if there's infection in the small intestines, this infection can also spread to the bile ducts. Tumors of pancreas and liver. When there are tumors in the pancreas and the liver, the tumors may cause blockage to the bile ducts. And when the bile ducts are blocked, they may cause constriction. When they are constricted by the tumors, there can be impairment in the flow of bile from the gallbladder and the liver. Then reduced blood supply to the gallbladder. Like I said earlier, that when the flow of blood is impaired, the flow of blood in the cystic artery is impaired, the gallbladder tissues may die. Gallbladder sludge, this also may cause infections to the gallbladder because sludge is a thick material that cannot be absorbed by the bile in the gallbladder. The signs and symptoms of cholecystitis. Mostly patients will present with intense sudden pain in the right upper quadrant of the abdomen, nausea and vomiting, fever, jaundice. Jaundice is the yellowing of the skin and the whites of the eyes, belly bloating, loose light colored bowel movements. So when a patient comes to the department, to the ultrasound department, and they are requesting for an ultrasound of the gallbladder, there is patient preparation that is considered. So the patients are advised not to eat anything for 8 to 10 hours before the test. Then the scan should be done preferably early in the morning. So on patient preparation, we prepare our patients where we prepare our patients so that it helps us. When the patients have not eaten, there will be less buildup of gas in the abdomen, and also the gallbladder ducts will not empty to digest food, and that will make it easy for us to see during the ultrasound examination. So the clinical history, as I said earlier on, I encountered 2 patients when I was doing my attachment, and this case study was on these 2 patients. So the names will be withheld. I'll refer them as patient 1 and patient 2. So this is my patient 1. It's a 17-year-old lady who complained of chronic pain in the abdomen, particularly on the right upper abdomen. She had nausea and vomiting and a distended abdomen. Her legs were swollen and looked puffy on the face. She had loss of appetite and fever. The patient also had shortness of breath. She also had a history of a cardiac problem, and this problem was discovered in 2021. The patient was very ill. So when I looked at the clinical history, because as a sonographer, you're supposed to go through the patient's history, the patient's file. When I read through the clinical history, my clinical hypothesis was cholelithiasis, especially that the pain was radiating on the right upper quadrant of the abdomen, cholecystitis, and chronic hepatitis. The investigative imagings which were done were ultrasound and echo. The sonographic findings that we found were the gallbladder wall was thickened by 5 millimeters. The patient had severe ascites. She had hepatomegaly. In mid-clavicular view, the liver was measuring 16 centimeters. Then the patient also had a positive sonography Murphy sign. A positive sonography Murphy sign is increased pain or discomfort that the patient experiences during deep inspiration when the sonographer applies pressure using the probe or the transducer on the location of the gallbladder. So these were the images. So this is the liver here, and this is the gallbladder. When we take a closer look at it, this gallbladder is shrunken. Then there is the wall thickness is quite thick. This is a gallbladder in longitudinal view, and this is the gallbladder of the patient in transverse view. The walls are quite thick. They were measuring about 5 millimeters thick. Then this is the fluid collection the patient had in the abdomen. She had severe ascites. The labs and the echo reports, the white blood cells for this patient were elevated. They measured about 12.5 microliters. And when I consulted the people from the lab, I was told that above 10 microliters is abnormal. Echo report revealed severe pulmonary hypertension and a dilated inferior vena cava. So on the clinical correlation, the patient's clinical history together with the ultrasound finding were consistent with each other. There was loss of appetite, and ascites could be one of the major causes of acalculous cholecystitis in this case. When the echo results were the white blood cells were slightly elevated, and the liver function test was they were in normal ranges. Echo results showed severe pulmonary hypertension, dilated IVC, which could be the cause of the severe ascites. So these examinations that were done on this patient were consistent with each other. Then my patient 2 was a 48-year-old female who presented with upper right quadrant pain that was radiating to the right shoulder. This patient also had nausea and vomiting, flatulence and bloating. The body temperature for this patient was normal. The patient also complained of abdominal pains after eating a fatty meal. This patient had no history of gallstones or surgeries. So looking at the clinical history again, my hypothesis was cholelithiasis and cholecystitis. The investigative imaging that were done on this patient were ultrasound and CT only. Sonographic findings were cholecystitis. The gallbladder wall for this patient measured 4 millimeters thick. She also had multiple gallstones. Steatosis. Steatosis is a fatty liver. This could be attributed to having a big body. This patient was quite huge. Then there was no biliary tree obstruction. Other abdominal organs were normal. The patient also had a positive sonography Murphy sign. These were the sonograms. This is the bladder in longitudinal view with multiple gallstones. So these white masses that we are seeing are gallstones in the gallbladder. There were quite many, and they are also casting a posterior acoustic shadowing. So this is the gallbladder in transverse view. Its walls are thickened as well. So the laboratory and CT reports for this patient, the white blood cells were normal for this patient. They measured 6.7 microliters. Then the CT report, the CT report revealed cholelithiasis with mild cholecystitis features. There was no CBD obstruction, common bowel duct obstruction, and the patient also had hepatic steatosis. The clinical correlation for this patient's clinical history together with the ultrasound findings were also consistent. The ultrasound results showed cholecystitis with cholelithiasis. The CT results also showed mild cholecystitis with cholelithiasis. And cholelithiasis is one of the causes of cholecystitis, acute cholecystitis or chronic cholecystitis. The white blood cells for this patient were normal. So on the limitation, like when I was attending to these two patients, I didn't have much challenge with patient 1, but I had challenges with patient 2. Sorry, I didn't have much challenges with patient 2, but I had challenges with patient 1 because she was quite sick and very tender. She kept on running out of breath. So it was quite a challenge to get good images, and the patient was unable to follow instructions properly. The ultrasound was done in the shortest possible time for this patient. My conclusion, from the two patients that I encountered, my conclusion is that cholecystitis is a clinical diagnosis. Well-trained clinicians clinicians can diagnose the disease based on the signs and symptoms a patient is having and the patient's history and physical exam. So my other concern or emphasis is the knowledge on emphysematous cholecystitis, since emphysematous cholecystitis is a rare and deadly variant. Sonographers are supposed to have an idea of this variant of cholecystitis. Then a higher rate of accurate diagnosis of cholecystitis can be achieved using a triad of positive Murphy sign, elevated white blood cell count, and an ultrasound showing polylithiasis or cholecystitis. These were my references. You can go through them when you have time. Thank you so much. This is the end of the presentation.
Yes. Okay, thank you so much, Joyce, for this presentation. And right about now, we'll go into a question and answer session.